Hi, my name is Allon Bloch, and I'm going to talk to you about K-Health and more broadly, how we're trying to apply a different approach using data in the world of health and healthcare. So, what am I doing? So, K is about connecting the world's health data. There's a fundamental issue for all of us, and that is our data all sits in silos if it sits there at all. Data is spread across multiple electronic medical records or in our memories, and it's impossible to access that data. And without going into too much details about it, it's all built for billing, especially in America. I'm still going the wrong way. Hang on a second. This is jumping slides, so I'll use a computer. Let me start again. That looked like, okay. So this was my first slide. That was threw me off. So there is a fascinating problem with health. If you go online and go on Dr. Google and Google yourself, you'll find information that is just fascinatingly off, wrong, irrelevant. And my team has about 20 doctors and 20 mathematicians, and I'll put a doctor in front of Dr. Google, in front of WebMD, and doctors will say, how come this is legal? How come people can search for information that is blatantly wrong, that's scary, that's irrelevant? And it's just a mind-boggling situation, because health is more important than our money, our house, our travel, and yet we have solutions for all the other problems. And one other thing specifically in the US, and this is not a political statement, but the cost of healthcare in America is much, much more expensive. Cost of healthcare in America is much, much more expensive. You'd think we live 200 years because healthcare costs just about 3 times more than what it costs in Europe. And we're still facing the same healthcare problems that we faced 30, 40, 50 years ago, and often worse. Diabetes, heart, cancer, stroke. These are still fundamental issues that haven't been resolved. Just to put things in perspective, the US healthcare market overall, not including fitness, sleep, diet, all that good stuff, just healthcare, sick care, is $3.5 trillion a year. The US military is $660 billion. So you can have 6 militaries, or 5.5, I should be accurate here since it's data driven, every year. And it's just a huge number. So we started K about 2.5 years ago around a basic core concept, which shouldn't be a surprise to any of us. You're not patient zero, or you're not customer zero. There's 7.5 billion people on the planet, and we all somehow are connected. But nobody's created a fabric to connect that in terms of data. And not only consumers don't have access to that information in a very timely and helpful way, but also doctors. If you use the content management systems that doctors use in hospitals or in clinics, the most popular one is UpToDate. It looks like a content management system from 1990 or 1985. It's a heuristic-driven system. It doesn't really help you understand the patient and the problems, and it doesn't create this magical data set. So this is a slide that kind of threw me off, but we said to ourselves, gee, wouldn't it be magical if we can create a data set and connect everybody through a data set based on what we call people like me. And people like me is, if you know evidence-based medicine, it's your core biology. It's your gender and age, which matter a lot. Sorry. I'll look back to see if people can hear me. It's your gender and age that matter a lot, and also your very, very, very specific symptoms and medical history, and then everything else that matters. Well, everything matters. We don't necessarily know a lot about your geography in terms of data and how it impacts your health in terms of influenza or Zika or anything else. It also tied to your genes, your wearables, anything else that could potentially count. So we said to ourselves, how do we get access to a vast data set? And can we train a data set that's rich enough to build what doctors call differential diagnosis? So we licensed a very large data set from an HMO out in Israel that has about 20 years of data. The HMO is similar to Kaiser. That means it's vertically integrated. They only own doctors and hospitals and labs and drugs. And people don't switch in and out of the healthcare system. And there's no billing recorded there. It's built just for health and wellness. So we got a large set of data that was mostly unstructured. So we got, for example, 80 million doctor's notes. And a doctor's note might say exactly the same thing that's written in most countries. Somebody's coming in complaining about a sore throat for 3 days. They don't have a fever. They have a light cough. They've got a nasal congestion. And then the doctor provides a certain diagnostic. The diagnostic might be subject to further review based on a test or a lab or an image. And then there's a whole process. People go through a process. So we essentially took 80 million doctor's notes that have all these different symptoms and sub-symptoms and then diagnosis and treatment, and tied them all in together and essentially trained a machine through ontology to build a differential diagnosis, to be able to predict what people might have based on our core mathematical approach of people like me, which I mentioned earlier. And so if you are able to create at large scale, we have about 500,000 people, but we just launched our product about 6 months ago. So if you have tens of millions or hundreds of millions of people using a system, you can capture the experience of a user. You can train the classification system and the ontology and make it richer and better. And then potentially provide a services layer on top of that. So we have not only an information layer, i.e. the ability to understand and predict what you might have, your head hurts, your stomach hurts, whether it's acute or chronic, whether it's serious or non-serious, but also be able to connect to remote care and get treated by a doctor. So I'll show you a short demo. This is going to be a 3-minute demo. I'm Lauren in this demo, and okay, and I'm feeling nauseous, and I use K, and this is our app. This is, I know it's not a design theme, but we built our app in color, and we built it in a way that doesn't look clinical, doesn't look black and white. There's no doctors and stethoscope. And right now, I'm going to have a conversation with the machine, with AI around my condition. So in this demo, I'm Lauren. I'm a 30-year-old woman, and I'm not feeling well. I'm feeling nauseous. So I put in, my core symptom. I'm nauseous, and from here on, I'm starting to have a conversation with the machine. All the questions here are driven by the fact that I gave basic onboarding information, my gender and age, and then my very specific symptoms and medical history. So I always say we can all play doctor, right? If you have kids, you always like, your head hurts, when did it start hurting, how long, did you get a bang, do you have a fever? Question number 5 kind of becomes really, really complicated. That's why you can't do 2 courses and become a doctor. There's a lot to learn. Nausea, vomiting, fever are tied to many, many, many different things. Medicine itself is not an easy profession. So training a machine to try and do differential diagnosis, to try and figure out what's going on is not trivial. This is not general artificial intelligence. You're having a conversation with a machine that's trying to do 2 things at the diagnostics level, to try and figure out what's the next best question to ask given what we know about you, and when we feel like we know the answer and we should stop asking questions. So the machine asked me when my nausea is starting, and I said today, and I said, I think it's from eating, and then I go and change my answer. There's no decision trees here. This is not a rules-based system, and I said, I think it's from suspect food, and I said, I'm feeling very nauseous. What is very important is, and this is again more of a marketing aspect, but behind the scenes what Kay is doing, it's comparing Lauren, the 30-year-old woman, to people like me. And you'll see this number here, this 81,000 number, change over time. Because the comparison is to that magical data set. And just to be very clear, a doctor in Mayo Clinic does not have access to this information. There's no medical grade system that allows you to compare yourself to a data set that's as rich and relevant as you are. And I said, I don't know if my nausea, if it's gradual or sudden. And I said, I'm also feeling, I'm also vomiting. And again, we use these symptom cards that people really like. And then I said, I'm feeling abdominal pain, and you can see that Kay now asked me where the pain is, which again is super obvious to people, but super relevant for doctors in terms of trying to identify what it is. A lot of what our machine does is ruling out, and this is very important. I'm just going to stop here and explain what rule out is. When people study medicine, they learn that if they hear hoofs outside of their window, and they live in America, it's probably a horse and not a zebra. A zebra being a rare and potentially dangerous condition, and a horse being a much more mundane condition. So if I'm feeling, if I've got a headache, there's very likely that it's a tension headache or migraine or sinusitis, and very rare that it's a brain aneurysm or something else. So a lot of what doctors do, I tend to think, is you paying a doctor for the rule-out. Because that is really, really important. The doctor needs to decide if there is a test that they need to do to rule out a condition. So on average, people answer about 20 questions, and it takes about 3 to 4 minutes. It's not a quick process. And in the end, when the machine thinks it's done, it shows you a screen which is essentially what we call an information revolution screen. It shows you what people like you, in this case, Lauren, ended up having. And I can go and see, in this case, the machine thinks it's food poisoning, and I can go and see what to watch out for next, the TLDR of what the user might have, what symptoms to look out for, what doctors people like me went to see, what drugs they took. And again, this information, if you open UpToDate or PubMed, is not segmented in a way that's helpful for people to understand. The doctors don't have this information. We show people what specific drugs they could take, whether they're over-the-counter or prescription. In New York, and this is something we're rolling out nationally, you can also share it with a physician. And in this case, I've already established care, so I jumped on all these steps, and I shared it with a doctor. And this is what a doctor sees from the other side. So it's a HIPAA-secure way of sharing information with the doctor, and the doctor gets that same health dialogue that I saw earlier, that I showed you earlier. They can go and see the positive symptoms, the negative symptoms. They can see what questions to ask. And a doctor can also send a response back, whether it's a reassurance, whether it's come in, or whether it's go to the ER. And I'm going to continue here, and this is also something really important that you can do with an app and a direct connection to people, because Kay can follow up with you. So it follows up with Lauren, and Lauren, the machine now knows that 6 hours have passed, and also she was feeling nauseous and probably had food poisoning. And now the pain shifted to the lower abdomen. And Kate continues to ask questions, and I said changing positions, and changing position made things worse, and I lost the appetite. And now the machine essentially recalculates the diagnosis here. So, and I'll show this in a second, but just to be very clear, when somebody's released from the hospital, doctors in their morbid sense of humor have a sticker called, "Call the patient to see if they're alive the next day." So this is a bit less crude than that. And again, these are our lives in hospitals today. This is not medieval. So now Kay thinks there's a high chance of appendicitis. There's still a chance of acute food poisoning. There's a chance of kidney stone. And I built this case because we've had several cases on this in Kay, and one of them was memorable for me because we had a user that used Kay and said, "I never go to doctors and I never go to hospitals, and I use Kay because my pain never went away." And Kay told me it was appendicitis. So I went to the hospital. By the time I got there, my appendicitis ruptured, and you saved my life. Now, I've built big companies over the years. One of them is public on NASDAQ, but nobody ever told me, I'm going to pause this here, but nobody ever told me that we saved their life. And I think that is the potential of doing stuff in health, fundamentally doing it right. So I think if you think about healthcare and you see all the politicians bickering about how to fix things, it's using intelligent software, doing most of the stuff remotely. There's no reason why it shouldn't be done that way. And once you believe that you can build stuff better than WebMD and other solutions and make them personalized, it's just so much more valuable. Just imagine a place where you can keep your young kids, your aging parents, all that information gets smarter about you over time. So I tend to think about it, it'll be 10 more seconds, but it's around control and convenience matter a lot, and when you give people control, the whole health system would change. It's about vastly lower cost structure, and it's about connecting people's knowledge. But fundamentally, it's around connecting human disease, building a better understanding of comorbidity and complex human conditions. And that's something that really we all deserve. Thank you.
Thank you. Just one or two questions from me, and then we'll open up to people. Just a handful of questions. So machine learning is great at sifting through massive amounts of information, but it's not always great at being reliable, right? It works for most of the cases, but not all of the cases. How do you think about responsibility, I guess, in terms of not making the right recommendation or the right analysis?
So I think that's a crucial element of what we're doing. So bear in mind, at stage one, and the app that we have outside replaces WebMD. So I look at it and say, wow, if 60 million Americans every month are willing to use something that doesn't work, well, if they use something that works pretty good, it's so much better. And the reality in medicine, there's no absolute solutions. You don't know. You ask doctors, if you go and speak to ER physicians that have seen enough cases over the years, they'll always say horrible things happen. So there's no 100% accuracy. But bear in mind, when you go to the doctor next to the Harvard or Stanford medical degree, it doesn't say 92% accuracy for the last 5,000 people. They don't measure accuracy. They don't even know how to measure it because they don't have a closed loop of data. So I think you need to build these things right. If we sit here and say, okay, somebody might die and people will die, and therefore we shouldn't be helpful to people, we're just doing ourselves a disservice around heart attack, stroke, diabetes, acute, all these different things. I don't think medicine is, at the primary care certainly, hasn't changed since our parents were kids.
And from a business standpoint, this is a B2C strategy all the way, or at some point you will perhaps help doctors come up with at least the initial triage?
We have a fair number of partners that I can't speak about that are really keen to be part of this. This includes big cardiology centers that want to use it with their outpatients, and I just have a line of nurses that are trying to triage people. We have large payers and large providers that want to work with us. There's large companies. Comcast is a big investor, and they're rolling out KR2. They have about 200,000 employees. So I think we'll try different things. Honestly, the market's so big, and there's so many things, we can't do it on our own. And I'm from Israel, so I like to do things on my own. But there's a limit here. And plus, you have Apple, Amazon, and Google that are very likely to be in this market and probably compete directly here.
Mm-hmm. Great. Do we have questions? Jack has a microphone.
Thanks so much. To tie back to that question about making predictions, are you measuring at all the certainty or uncertainty of your predictions? By which I mean, you use Bayesian deep learning, you use other alternative techniques.
We measure a whole host of things around accuracy. So we not only look at what consumers self-report through that follow-up, but we also probably work with about 100 doctors that provide us anonymous response back around our diagnosis. And again, we've had situations that we were wrong. We have situations that the doctor in retrospect was wrong and they've changed their opinion to us. So we look at recall very closely. We look at accuracy. But let's assume, I think the core goal from my perspective is actionability. If somebody has a very high chance of a tension headache or migraine based on what we know, and a very low chance in some horrible condition, we need to tell them it's a high chance of A and B. And they need to do a rule out. They need to do typically a test or a lab work to rule out something. And so for me, that's 100% accuracy if we get all those things right. But again, we just assume, I tell my board, rich people in big cities think they have great doctors. If you've heard of Lyme disease, you know somebody who was misdiagnosed by Lyme disease, which is a serious condition if you don't get it right. So it's not like everything's perfect out there and free.
Just one more.
What made you pick this topic? You said you started a company before. Was it a personal experience, or what made you? Because, like you said, there's a lot of competition coming for sure. What made you pick this space?
I was always interested in data problems and how I can repackage in a way that's helpful for people. And I think there's a reason why data is made complicated, and there's a reason why it's made simple. I think it's one of the big problems we're facing, and I look at health well beyond healthcare. So it includes how we sleep, how we eat, nutrition. And I'm always, to me, it's mind-boggling that every decade we change our view about nutrition. We're going to eat what people ate 50,000 years ago, or we're going to eat fat, or we're going to eat sugar, or not fat, or yes, sugar. And all that is based, if you go to the underlying studies, it's based on limited data. Everybody's jumping to conclusions. I don't know if I need to eat like people ate 20,000 years ago. It's always, everybody's certain, and there's an article and the headlines out there. Tea is good for you, tea is bad for you, coffee is good for you, coffee is bad for you. Most food we eat, at some point somebody said, is cancerous. You know, it just doesn't connect. So I think there's a basic societal need. How come we can control our money and we control the restaurant we go to eat in Fiji, and yet we can't know basic stuff around our health? And so, yeah, it was basic experience that I've had and my loved ones and my co-founders around either misdiagnosis or mistreatment. So why not, before you go to the doctor, at the doctor, after the doctor, arm yourself with information that's relevant as opposed to irrelevant and scary.
All right, very cool. Thank you so much, Allon.
Thank you.